Okay, well, I want to welcome everyone to our Thursday morning grand rounds. Glad that you're here. Hope people are coping well, staying safe and healthy, you and your family and friends. Just an announcement for our next upcoming HIV Center grand rounds, which will be on March 18th. We have two of our postdoctoral fellows talking with us that day. The first one would be Liad Timmons, talking about sexual identity, sexual behavior, and pre-exposure prophylaxis in Black cisgender sexual minority men. This is information data from the N2 cohort study in Chicago. And then second up on that very same day, March 18th, is Afole Mbako, whose title of his talk is Black Lives with HIV Matter, Addressing Systemic Racism on the Journey to Sustainable Undetectable Viral Load for Black MSM. As you will see, including today's presentation, we've really tried to emphasize the focus of our research presentations on issues around health disparities and inequities, racism, et cetera. So today, we're very, very pleased to have Dr. Monica Rivera Mindt, who is a cultural neuroscientist and a board-certified neuropsychologist. She's the immediate past president of the Hispanic Neuropsychological Society and a tenured professor of psychology and Latinx studies at Fordham University. And she has a joint appointment in neurology at the Icahn School of Medicine at Mount Sinai. Her multidisciplinary community-based research is funded by the NIH, National Institute of Aging, Alzheimer's Association, and primarily focuses on the intersection between cultural neuroscience and health disparities in cognitive aging. A lot of us are growing increasingly interested in this domain of research, so I'm so glad you're here today, Monica. Her current studies are examining Alzheimer's, cerebrovascular and sociocultural risk factors of dementia in older Latinx adults. In addition, she is the co-lead of the NIA-funded Alzheimer's disease neuroimaging initiatives and diversity task force. I could say a whole lot more. I'll just say a little bit more. She's a recipient of several awards for her research, teaching, and contributions to the field, including the 2019 Hispanic Health Leadership Award from the National Hispanic Medical Association. She's also a fellow of the American Psychological Association, the National Academy of Neuropsychology, and Hispanic Neuropsychological Society. So she's speaking with us today on health disparities and neurocognition in the context of HIV. Dr. Mindt, we welcome you. We're honored to have you, and I'm going to turn it over to you.
Wonderful. Thank you very much, Dr. Remien. It is such an honor to be here with you and everybody virtually this morning. It's great to be here. Thank you so much for having me. So as you see here, the title of my talk is Health Disparities in the Context of HIV. You already know quite a bit about me. The only other thing I'll mention is that I have been interested in this work and health disparities for the past, gosh, almost 20 years. And while it is the case that I'm a cultural neuroscientist and by training a board certified neuropsychologist, I really, in my heart and soul, first and foremost, consider myself a health equity scientist. And so the whole presentation today will be from that lens as well. And you see my foster cat, Barbara, here in case anybody is looking for a cat. Hold on, Barbara, go, sorry.
All pets are welcome.
Thank you. Okay, then she's probably going to make another appearance, as might some of my other animals. So please bear with me. Sorry about that. So before we get started, I want to begin with the land acknowledgement. We acknowledge the people of the tribal nations and tribes here in New York City, the Lanai, Lenape, the Cayuga, Mohawk, Erie, Seneca, and Oneida, who are the traditional custodians of the land on which we work and live, and recognize their continuing connection to the land, water, and air that the United States consumes. We pay respect to their elders, past, present, and emerging. Here briefly, you see my disclosures, and I have no conflicts of interest. And in another acknowledgement disclosure, I will just say that we are coming together in this moment of, unprecedented turmoil and turbulence with multiple pandemics going on. And I just want to thank everybody for being here and for, just, making it happen every day in all the ways that you are, because I know this is a really difficult time. And I'm just so honored and grateful that you're joining me here today to talk about health disparities. In terms of the structure of today's discussion, I'm going to begin very briefly with an overview about how I'm thinking about this talk in this moment from a historical perspective. And also, I'll just provide a brief overview of demographics. Then we'll discuss HIV-related health disparities, HAND disparities, HAND standing for HIV-associated neurocognitive disorders. Then I'll talk more about sociocultural factors in particular as they relate to brain behavior relationships in HIV. And we'll end with a call to action in terms of next steps and future directions. In terms of a historical context, I think it's important to take a step back and really think about where we as HIV researchers and individuals who are interested in this topic, how we place ourselves from a historic perspective. And growing up, I came up in the the 80s and 90s. I grew up with the HIV epidemic. It personally affected my family. I had one of my closest cousins died of HIV in the 90s, and it was a very formative part of my experience growing up. But as we take a step back, over the last century, we've experienced now 3 major epidemics or pandemics in the course of the history of our country. So if we think back about 100 years ago, we had the Spanish flu. And it turns out that the Spanish flu also had a significant disproportionate impact on vulnerable populations, particularly Black African Americans, immigrants, indigenous populations, and on and on. And here in this picture, I don't know if you can see my pointer, but here in the top left of the screen is a historic picture that shows just how oversaturated and bombarded Black hospitals were all over the country with people with Black African Americans suffering from the Spanish flu. So again, even at that time, we saw this disproportionate impact. Although in terms of mortality, and again, I don't know that the epidemiological data, how reliable the epidemiological data are, but while the Black African American population and others were disproportionately affected in terms of access to care and what it meant in terms of the economic output. It's unclear in terms of actual epidemiology what the prevalence was of the Spanish flu, but certainly these were populations who were very hard hit during that epidemic about a century ago. Then we cut to late into the 20th century, and now continuing on into the 21st century, we see that HIV has had a massive impact on public health here in the United States and throughout the world. And again, we see that Black, Latinx, and other diverse and vulnerable populations are again disproportionately impacted. And cut to the last year. Same story. We have another pandemic at the terrible, coronavirus. And again, we see a disproportionate impact on vulnerable populations. And I highlight this historical context to reinforce that this is a reoccurring theme. It's not unique just to HIV, but there's something about infectious disease and vulnerable populations, right? That those vulnerable populations, be it because of socioeconomic status, ethnocultural status, what have you, they tend to be disproportionately affected, and we're living through that now. And I strongly believe that the lessons we've learned from the HIV epidemic have significant implications in terms of lessons learned that can inform the current pandemic with coronavirus. In terms of demographics, we've seen this really tremendous change in the US demographics in the last 25 years, in the last century. Over the last century, if we cut back 100 years ago, about 1 in 8 people living in the United States was what we would consider somebody from an ethnoculturally diverse background. So somebody who's Black, Latinx, Asian, American Indian, Alaska Native. So somebody who is not European American or non-Latinx white. Cut to 100 years later, in our day and age, we see that about a third or so of the United States population comes from what we would call an ethnoculturally diverse background. And here you see in the pie chart that these statistics are from 2010, so I have to update them. But now, actually, about 18% of the United States population is Latinx. About 12-13% are Black non-Latinx, about 1 to 2% American Indian, Alaska Native, and so on. So you see the demographics here. But if you look on the right side of this screen to the graphs, you'll see that by 2050 we're going to experience even greater diversification of the United States. So if you see here for 2050, by that time we will have a significant shift where European American individuals will make up less than half of the United States population, so about 46% if current estimates hold. And about a third of the United States population will be Latinx. The Black population is appearing to hold steady around 12%, depending on different people's estimates. And something else that I think is really important to note is that we're going to see a significant increase in the Asian population, really the Asian diaspora. They're going to be almost doubling. So if you look here in 2010, they made up about 5% of the population, but in 2050, they're slated to make up about 8%. So here we see this increasing diversification of the United States that has significant implications from a public health perspective. I also note here that we're also seeing tremendous linguistic diversity in the United States at this moment. So we have about 1 in 5 or 21% of individuals here in the United States speaks a language other than English. I put a box around Spanish, so that's it's my first language. So we have over 40 million people living in the United States who speak Spanish. But I also want to highlight to you that of the top 10 languages, a tremendous number of them are represented in the Asian diaspora. So this is also a really important population that we need to be paying attention to as well. In terms of highlighting specific segments of the population that I want us to be mindful of in terms of public health, another really important one is the aging population, 65 years and over. And here again, we're seeing a diversification of the older population. So what this slide and graph is meant to convey to you is that between 2008 and 2030, the Latinx population, so that 65 and over segment, is growing at 3.5 times the rate of the non-Latinx white population. So that's a tremendous shift and diversification in the older population. And while I don't have the graph here, it's also true that the Black African American population is also their slope in terms of diversification in that 65 and over segment is also growing at a rate faster than the non-Latinx white population. So taken together, what does this all mean? Well, I think that for us, we need to be thinking about infectious disease, certainly as it relates to vulnerable populations and public health more broadly, absolutely. And that we should be thinking about these health disparities in the context of how they do continue to creep up, especially when it comes to infectious diseases and epidemics and pandemics, disproportionately impacting those populations that are most vulnerable in our society. I also want to highlight that U.S. demographics are rapidly changing, and they're especially changing in really important segments of the population that we need to be mindful of, particularly, Latinx, Black African Americans, certainly the aging population in the United States as well. And together, this all has major import and really should make us think about how this all impacts public health. In terms of HIV health disparities, first, what can I say? All residents here in the United States are not equal in health. We know that people here in the United States are not equal in terms of life expectancy, in terms of mortality, morbidity, access to healthcare, quality of healthcare, and health outcomes. We know that there are significant health disparities, but just to put a finer point on it, when I talk about health disparities, I think it's really important that we're all on the same page. So what do I mean? So I'm talking about the disproportionate prevalence, incidence, and outcomes of illness and disease in specific populations compared to the general population. But that's not enough that there are just these differences, right? Because we see differences that are related to other population-based issues that don't count as health disparities. So, for instance, I'm thinking about sickle cell anemia. So we know that sickle cell anemia impacts, you know, Black African Americans, for instance, in the United States at higher rates than European Americans. But that's because of a mutation on a gene that confers resistance to malaria. So that's different. That's not a health disparity per se. What makes a health disparity condition a health disparity is that it's mutable and it unduly impacts vulnerable populations along very specific lines that have to do with things like ethnocultural status, gender, wealth, socioeconomic status, LGBT status, and the like. And HIV certainly counts as a health disparities, and it really reflects issues of systemic inequity and inequality that exist both at the structural level and the individual level. And I hope we'll have some time to talk a little bit about that as we move forward. So here, so we just talked about the different United States demographics for different ethnocultural group, and now I want to highlight the prevalence of HIV in some of those same groups. So as you see here, even though the United States Black African American population only makes up about 12% of the population, they make up about 44% of people living with HIV. Similarly, with the Latinx population, while they make up about 18% of the US population, they make up about a quarter of people living with HIV in the United States. And so together we have, so let's see, those two populations make up about, less than a third of the United States population, but they make up about 2/3 of those living with HIV in the United States. So that, just in terms of prevalence, is a significant health disparity in and of itself, especially when you think about not only that, but infection rates. So new infections in HIV, while they've gone down overall for the European European American population in the United States, they have not had the same trend for new infections in Black and Latinx populations. So there we still do see growth. And I also want to highlight that down here at the bottom, it's rest of population. I don't love that. That title. I'm going to change that next time. But what you see is we see very low, I guess, prevalence, relatively speaking, or it doesn't seem like a health disparity because it's about on par or a little bit off for the Asian, Native Hawaiian, and other Pacific Islander populations at 2%. So a little bit of an imbalance there, but about consistent for American Indian and Alaska Native populations with 1% prevalence. But I have some notes of caution here. So we don't have really good epidemiological data to really understand what's happening in the Asian diaspora or the American Indian and Alaska Native populations as well. So that's one thing I want to note. And second, we also see that between 2011 and 2015, we also saw rising infection rates in HIV for gay, bisexual Asian men, and declines and difficulties with access to care, retention, and viral suppression. When we look at the American Indian, Alaska Native population, we also see an increase. So in the same time frame, just only in 4 years, we saw a 54% increase in HIV in persons who identify as Two-Spirit, which is in American Indian culture, the term that would reflect people who in I guess majority culture might call transgender or gender nonconforming. So I guess the main thing I want to just highlight here as well, I'm going to focus on Latinx and to a lesser degree, Black African American populations. It's really important that we don't lose sight of these other populations who are underrepresented in research and for whom I believe we don't have as good epidemiological data. So much of my work is focused on the Latinx population, Afro-Caribbean population. So that's some of the health disparities I'm going to highlight now. And so what do we know? We know that the risk for HIV among the Latinx population is 3 times the risk for non-Latinx whites. They have significantly increased mortality rate. Not only that, they're more likely to die at a younger age. They have lower levels of care engagement and lower viral suppression. And we also see, as I'm going to share later in this presentation, a higher prevalence and severity of cognitive impairment. So we see very significant health disparities across a number of metrics. Not only that, we know that thanks to being in the era of improved therapies with combined antiretroviral therapies, people are living longer, including people who of all backgrounds, so that people who are now considered older adults living with HIV, which is 50 and above, that population is significantly growing as well, and thank goodness for that. And if current trends are maintained, we'll see that by 2030, by some estimates, 70% of people living with HIV in the United States will be 50 and older. So, so this issue of aging is also really important to keep in mind as well as we think about the HIV population. So key takeaways from this section. Number 1, HIV remains a leading public health problem. And I didn't mention this earlier, but we know that over 1 million people are living with HIV in the United States. This is still a major issue. Not only that, HIV unduly impacts the US Black, Latinx, LGBT plus populations and other diverse populations, including the Asian diaspora, American Indian, possibly, and Native Alaskans. So not only are they at increased risk for getting infected with HIV, but once infected, they're more negatively affected with worse health outcomes, including increased morbidity and increased mortality. Before I go on, I just want to check in. Is everybody good? Are we doing okay so far? You can unmute yourself for a second. Everybody doing okay?
Yeah, I think all's good.
Good. Okay.
Going
great.
well. We hear you great. It's all
Okay.
very clear. Thank you.
Okay, great. Thank you. And if there's any technical problem or any issue, please let me know. My worst fear is that I'll be talking for an hour and nobody can hear me. So please let me know.
All's good.
Okay, great. Thank you. Let's see. Okay. All right. So next, what about disparities in HIV-associated neurocognitive disorders, or HAND? So I've spent a great deal of my career focused on trying to understand these issues, to document them and understand them. So what we know about HIV is that not only is it an immune medical condition, but it's also a neurobehavioral condition that has significant impact on the central nervous system. So it impacts, the brain and peripheral nervous system as well. I call this my roller coaster slide. So Igor Grant from UC San Diego, where I did my my postdoc, shared this with me many years ago. And while it's got a lot of years on it, I think it's a really useful slide to just get our minds around the course in HIV. And so for folks who are interested but not as familiar, I like to share this slide just to give everybody a sense of the life course for HIV. So what we know is at the time of infection, individuals might have a slight increase in medical events like a flu-like symptoms and what have you. And when that happens, there's also an increase in HIV viremia or plasma RNA, which you see in the red line. And there's also usually a brief decline in CD4 count, which is a marker of immune function. So it's our white cell count. And so so when this is low, that's not good. And when viremia is high, that's also not good. But this is short-lived. And as our bodies then, develop, a resistance and immunity, some immunity to HIV, we see that these these things change over time. So over time, then we see a plateau, a lowering of plasma viral load, and then we also see this the HIV antibodies stabilizing off, and we see that there is a resurgence in CD4 count. And so this is how things, so people stabilize for a time. But if people go untreated, over time, CD4 count will go down. We will see viral load go up, and we will see medical events. So the classic, symptoms of HIV. So Kaposi sarcoma or different opportunistic infections start to emerge. But what I want to highlight about this slide is that, HIV is a neurotrophic, virus. It has a predilection for the central nervous system, for the brain. And so it can cross the blood-brain barrier early in an individual's infection, and it can actually have an impact, including a cognitive impact, before individuals get to a more severe stage of disease progression otherwise. So we can start seeing cognitive impairment and other central nervous system manifestations before we even get to this point. And I think that's important to remember. So it's, when we think about HIV, I think broadly, in popular culture, people don't really think about HIV as a neurologic condition, but it certainly is. And so while folks might think about other diseases, so certainly, like Alzheimer's, they might readily think about Alzheimer's as potentially being a brain health disparity, because it disproportionately also impacts Black and Latinx populations in the United States. HIV also has this disproportionate impact in terms of negatively impacting brain health in these populations as well. And I think that's really important to remember too. Okay. So here, this is a very busy slide, and I do not expect anybody to go through and read every word right now, but I do offer it just to give you an overview of what, when I say HAND, or I'm talking about HIV-associated neurocognitive disorder, I think it's important that we operationalize our terms. And so I'm working from Antonori's paper. So that group in 2007 updated the criteria for HIV-related neurocognitive disorder. And so you see it here. So we have three different main categories. So there's asymptomatic neurocognitive impairment, which we might consider like MCI in another context. So this is when individuals have some mild impairment in at least two cognitive domains, but it's not impacting their everyday functioning. The next is HIV-associated mild neurocognitive disorder, where here we are seeing at least two cognitive domains. So it could be attention, learning, memory, what have you. So we have at least two domains that are impacted, negatively impacted, and we're also seeing that in combination with mild interference in daily functioning in at least one area. It could be, problems with work or with, activities of daily living, what have you. Then we have HIV-associated dementia, which is a full-blown dementia. And here we have moderate to severe cognitive impairment with significant interference in everyday functioning in could be in multiple domains, and we can't explain it by any other cause. So we can't explain it by some other etiology. So it does appear to be related to HIV. And in the course of improved antiretroviral therapy, so since about the late 90s, we've seen a decline in HIV-associated dementias, but we've seen an increase in the prevalence of mild neurocognitive disorder, right? So people are living longer, and they're and which is wonderful, but we're seeing that while the severity of cognitive impairment here in the United States seems to be overall, that prevalence of dementia seems to be going down. We are seeing a relatively high prevalence of milder forms of cognitive impairment continue even in the era of these improved therapies. And to that point, I want to highlight this study here. I'm going to take a water break. So the charter study is, to my knowledge, one of the biggest uh, studies to look at HIV-associated neurocognitive disorders in the era of these improved therapies. So this is a study I was a co-investigator on here at the Mount Sinai site. We were one of 6 sites all over the country, including my close colleagues at UCSD, University of Washington, Washington University, Johns Hopkins, and Galveston in Texas as well. I believe that's all of them. If I've missed anybody, I apologize. I should have listed them out. So here in 2010, we published the cross-sectional findings of this study. So we had about 1,500 individuals in the study. It was a pretty ethnically diverse sample. And what we found was even in this era of improved therapies, we still saw a very high prevalence of neurocognitive impairment. So about 52% of our sample had qualified for global neurocognitive impairment. So that in and of itself, I think, is a really important study because we were very interested and I think hopeful to see a lower prevalence of overall neurocognitive impairment in this era of improved therapies, but that's not the case. So even though people are living longer with HIV, they are still continuing to be at high risk. So like 1 in 2 chance of having cognitive impairment based on this study. Although I want to say that other studies have demonstrated lower prevalence. So if we look at other studies, it could be about 30%. So let's say somewhere between 30 to 50%. But nonetheless, a high prevalence of cognitive impairment. And the other thing I want to highlight from this study is that when we looked at ethnocultural factors, so when we compared people who were European American, Latinx, Black African American, the only group that where their ethnocultural status actually increased their risk for cognitive impairment was the Latinx group. So individuals, if they were European American or non-Latinx white or Black African American, they did not, after we accounted for comorbidities and other potential confounds, they did not have increased risk for cognitive impairment. But the Latinx demographic did. So I think that's also really important to highlight as one of the key findings of this study. In addition, in a follow-up study that documented the longitudinal findings of the charter study. So here, this sample included 436 individuals who followed up. In the charter study, we had 99 individuals who were classified as decliners, 265 who were stable, cognitively stable, and 72 who were actually improvers. So these different statuses relate to their cognitive status, and this is they were stable in other ways. And so what this study revealed, so there were many predictors of cognitive decline, but what I want to highlight to you, I've boxed out here, and again, I know that this is a busy slide, but in terms of ethnicity, only again being Latinx, Hispanic Latinx was the only demographic, ethnocultural demographic that increased risk for cognitive decline. So I think that these are really important findings, and I don't think that people have really talked about this as much, but I think it's important to highlight. In one of the biggest studies, post-CART that we have, we see that not only is Latinx ethnicity a risk factor for cognition cross-sectionally, but it's also a risk factor for cognitive impairment moving forward over time for cognitive decline. So I was really interested in looking at some local data that we collected to try to understand these findings better. And what we found actually is in our studies, not only did we account for comorbidities, but we also accounted for other sociocultural factors that I'm going to talk with you about later in this presentation. And after accounting for things like acculturation and quality of education that I'll talk about in a second, we found that there was a disproportionate increased risk for cognitive impairment in older Latinx individuals living with HIV. So if you look, so let me just walk you through the slide briefly. What we see here is that we separated these two groups into a younger group and an older group. So an older here is 50 and above, which counts as older in HIV. And so we then categorize these groups by non-Latinx white and Latinx. And after accounting for these different factors, we looked at different average T-score for the domains of global cognition and then a series of different neurocognitive domains, including verbal function, executive functioning or problem solving, processing speed, attention, learning, memory, and motor functioning. And after accounting for those different factors, we found there were no significant ethnic group differences. They were fully attenuated, as you see here. However, here in the older group, we saw either significant differences or pretty robust trends with large effect sizes for a number of domains. So we saw that these ethnic group differences persisted in terms of global cognition, processing speed, learning, and memory with large effect sizes. So what this says is, or I guess for me, what the takeaway is that the older Latinx population seems to be at potentially increased risk for cognitive impairment related to HIV, even more so than the younger group. And I also want to highlight that one of the dangers or risks that we take in doing much of the work that's done in HIV research and really research more broadly, I don't want to pick on HIV research, is that we look at the Latinx population from a perspective of pan-Latinx. So we know that, there's a Latinx diaspora. We have, Latinx people from, all over different parts of Latin America and the Caribbean, right, as well, who've come to the United States. And it turns out that there are also important reasons to think that we should be looking at at these issues at a more fine-grained level. And I'm going to explain to you here why. So this is a paper that Dr. Maria Marquine and myself and others published in 2018 in JINS. And what we were interested in looking at was really following up on the charter findings, which showed that Latinx individuals were at increased risk for both cognitive impairment and cognitive decline, and trying to understand that finding better as well. And so we went back to those data, to the charter data, and we looked first at just, again, comparing rates of actual cognitive impairment between non-Latinx whites and, I'm going to put this down here, and Latinx individuals. And what we found was higher prevalence of cognitive impairment across many domains. So the striped bar represents the Latinx group, and the solid bar represents the non-Latinx white group. And what you see is we saw significantly higher prevalence or frequency of impairment in the Latinx group in terms of global cognitive impairment. Almost here, I think it's over 50% in terms of executive dysfunction, processing speed, learning, memory, and attention working memory. So really, significant disparities across the board. However, so that's between group differences. And I think we have to be careful when we do between group comparisons to make sure that we're asking the right questions and contextualizing the findings in terms of important sociocultural factors that we know we need to account for. And what we then did with these data is we then looked at within group findings. So here on the bottom, you'll see that we then compared Latinx individuals of Puerto Rican origin who were mostly from our site here at Mount Sinai in the Northeast with Mexican American individuals who were mostly from the South, from our Southwest sites. And what we found here was, I think, really important. What we found was that there were still significant disparities to be considered. So first of all, we found that our Puerto Rican participants had significantly higher prevalence of global cognitive impairment compared to our Mexican American participants. So if you see here, Mexican Americans had a prevalence of impairment at about 45%, and compare that to our Puerto Ricans who had impairment at over 70%. And the thing I also want to mention when we're talking about the Mexican American individuals in this sample, these were mostly, again, from the California, Texas borderline region with Mexico. And so they were, evaluated mostly at our UCSD and Texas sites. So these findings don't really speak to Mexicans from people who have origin from other parts of the Mexico borderland. And we also found that there were significant disparities between these two groups in terms of learning and memory. And so here you see that, the prevalence of learning impairment was, again, over 75%. And for memory, it was probably around 65% as well. So here, what this slide is showing us, or this graphic is showing us, is that we need to be thinking beyond Pan-Latinx issues when we think about HIV-related brain health, and really thinking more at a nuanced level when we think about unique populations. Because what this is saying is that from all of the different demographics in the United States for whom we have neurocognitive data, who we've characterized them to at least some degree, what this shows us is that Puerto Ricans here living in the United States have the highest risk of neurocognitive impairment, or HAND. And I think that's a really important takeaway message. In fact, when we disaggregated the data this way, Mexican Americans were no longer showing significant differences to non-Latinx whites, nor were, I'm not showing those data here, but our Black participants were also not significantly more impaired than our non-Latinx whites. So again, it's the Latinx group, and in particular, it's Puerto Ricans who are driving these disparities that we're seeing, which has important public health implications for future research that we need to be thinking, especially here in New York City at Columbia and here at Mount Sinai, where these are the populations that we're primarily working with Caribbean, Latinx individuals of Caribbean descent. So with that, let's start in the time we have available, disentangling some of the sociocultural factors that I think are really important for us to be considering when we think about HAND. And here I've listed them out for you. So I would argue to you that it's really important that when we are studying and thinking about HAND, both clinically and in terms of research and public health, that we need to be thinking about quality of education, not just years of education. We need to be thinking about acculturation. So and I'll explain that in a minute, socioeconomic status, and discrimination. So when I talk about quality of education, what I'm talking about is a body of research that's come out of actually Columbia and Jennifer Manley, her amazing trailblazing work looking at moving beyond just looking at years of education, which we know is important for understanding cognitive test performance, but looking at the actual quality of education. And Dr. Manley did quite a bit to validate these single word confrontation naming tests, which are very brief and easy to administer, like the RAT reading test, the Wechsler test of adult reading in English, and the word accentuation test in Spanish. So these are very brief, easy measures to administer. But it turns out that they're strongly related to markers of qualitative education, like per pupil expenditures, teacher-student ratios, and other really important markers of education quality. And so what we did in our lab at Sinai is we looked at between group differences in neurocognitive test performance between non-Latinx white and Latinx individuals. And then we also added into the model, we then did a series of regressions looking at ethnicity, socioeconomic status, and RAT reading, again, which is our proxy for quality of education. And I'm going to actually ask you not to pay too much attention to the SES measure that we used in this study, because we used just a zip code, which is a somewhat confounded, on its own problematic proxy for zip code, so I own that. It was, it was available data, and at the time that's what we had. But what I do think is really important from this study is to look at the findings in terms of quality of education and what we found. So I'm going to bring your attention to the regressions on the right side of this figure. And so if you look at quality or global neurocognitive average T-score, we found that after accounting for ethnicity, the effects of ethnicity and socioeconomic status, and CD4 count below, only quality of education significantly contributed to cognitive impairment. And I would really think about quality of education as as a cognitive resilience factor, right? So really, the more quality of education you have, the higher it is. That it appears that the more robust people's responses are to insults to the CNS. And here we see that this is really the driving factor in neurocognitive disparities in our two groups. And that was also replicated, that finding, in terms of risk for learning, difficulties, attention, working memory. The only place where this didn't bear out was in our analysis with executive functioning or abstraction. And here we found that it was actually ethnicity and socioeconomic status that continued to drive the disparity in neurocognitive test performance. And I have some thoughts about that, and I'll talk about that in a following slide. Which brings me to acculturation, actually. So acculturation has to do with really how, how identified with and facile an individual is with particular culture. And while we often think about culture in terms of identification to US culture, it's really a bidimensional construct where an individual can, gain mastery and identification with the new majority culture, as well as the culture of origin. So there can be cultural maintenance as well as cultural participation in a new culture. And I also think that's important. And I'm not going to get too much into those data, but we did find some interesting findings and discrepancies in the relationships between US acculturation with cognitive test performance in our Latinx HIV positive participants, and then the associations between Latinx acculturation or culture of origin and cognition. But in the interest of brevity, I'm just going to I'm actually going to skip this slide and talk about our findings from this study that we published back in 2012. And so what we found here was that accounting for US acculturation is important. It matters when we are looking to interpret neurocognitive test data. And of particular note, what we found here, we took a multidimensional approach to measuring acculturation. So Zia, who's has a really wonderful measure of acculturation that I think suits our population here in New York very well. In her measure, it includes language competence, cultural identity, and then overall US American identity. And what we found was that language competence significantly contributed to neurocognitive test performance, which makes sense and probably is not surprising. So that's okay. But you see here we found small to moderate effect sizes. Then what we also found, when you get to what I think is really important, when you get over here to to overall US American identity, what we found was that individuals who had overall greater acculturation or identification with US culture, they performed significantly better on measures of verbal fluency and processing speed, and their overall global neurocognitive function was also better. So while these are small effects, I think they're important effects, both statistically and clinically speaking, because what they show us, so they're not as robust as the findings in terms of quality of education, but they show us that acculturation is something that we also need to be thinking about when we're looking at neurocognitive test data. In terms of socioeconomic status, these this is a paper that we published back in 2015, and what we found was significant, univariate relationships between raw test scores across all of our neurocognitive domains with our adult and childhood measures of SES. Our SES measure was the Hollingshead, which I realize is old, and there are some issues. We can talk about that later if you want, but it was better than zip code. And again, we found with adult SES, we saw again higher SES was related to better neurocognitive test performance, and when you see the negative correlations, that has to do with the weighting of those raw test scores, so lower scores are better. And we also found significant relationships with childhood SES, that higher childhood SES was also predictive of better socioeconomic performance as well. And not only that, when we conducted some hierarchical regressions, we found that adult SES significantly, completely mediated the between group differences that we'd originally seen between ethnicity and these neurocognitive outcomes. So initially, when without accounting for SES, we saw these significant group discrepancies or group disparities that I already mentioned, where Latinx participants were doing worse. But when we accounted for SES, SES accounted for all of that variance, and ethnicity was no longer significant. Next, I want to talk about briefly about discrimination, and what we know. Again, we're now, I think, together consciously living through the structural racism pandemic, which has been going on for the last 400 years. But I think over the last year, with the tragedies with George Floyd, Breonna Taylor, and on and on and on, I think we as a culture have now come to be more aware about the effects of structural racism and discrimination in our society. And what we know is that overt, readily observable types of discrimination tend to be less common. So hate crimes or explicitly poor treatment, those tend to be less common. What does tend to be more common are those types of racism that are difficult to observe. And I intimated this earlier on, having to do with implicit attitudes and structural racism. And my dear colleague at, let me move this, my dear colleague at Mount Sinai, Dr. Urena Clark, who is doing some really spectacular research in this area, she did this really interesting study looking at this is a neuroimaging study looking at resting state data. And she looked at discrimination, so the effects of discrimination as it related to functioning in the brain. And what she found was greater discrimination was associated with greater amygdalar activity in very specific regions associated with stress, depression, and anxiety. So again, in the salient network. And I think this is really interesting because it shows that discrimination, not only, is it difficult and terrible in all these ways, but it can actually change brain function. Not only that, but my colleagues and I also did a study looking at perceived discrimination. So Dr. April Thames, who's now at USC and UCLA, Desiree Bird at CUNY, and others, we conducted this study with 92 adults. And this wasn't in an HIV sample, but I share it with you to highlight that. So the main story here, I'm running out of time, is that the greater perceived discrimination and greater stereotype threat, or essentially the greater expectation one has about racial stereotypes, the worse an individual's neurocognitive test performance. And I think that that's really important to highlight as well. So key takeaways from this part of our discussion today. I hope that you remember that cultural heterogeneity is really important, that Caribbean Latinx individuals and individuals from Puerto Rico have worse global cognition, learning, and memory. And this is a demographic that's at greater risk for HAND in the whole United States out of all of the different demographic ethnocultural groups that have been studied with, substantively. Second, I want you to remember that quality of education matters. Lower quality of education is associated with worse global neurocognitive functioning and worse neurocognitive function in most domains in people living with HIV. US acculturation, and I didn't talk about it here, but bilingualism can also have an effect. So greater identification or acculturation to majority culture is associated, oh, I see a typo here, so forgive me for that. Greater acculturation to US culture is associated with better global cognition, processing speed, and attention working memory. In terms of socioeconomic status, worse socioeconomic status is associated with worse processing speed, attention working memory, learning, memory, executive function, and verbal functioning. So across a number of domains. Lastly, we know we have some research to suggest that discrimination changes brain functioning, especially in the amygdala, and that it can negatively impact global cognition, learning, and memory. And with that, I'm going to wrap up and bring you to our call to action. So I want to briefly talk about some takeaways that I want to highlight to you overall. And I also just want to celebrate the idea of brain health equity and what we're all striving for, and how, even though this is obviously a very difficult moment and we're talking about a condition that has negatively impacted so many individuals, families, and communities, I think that we have to look at the work and think about how we can positively impact health and our society by positively contributing to neuroscience research, neuropsychological research, public health, and society more broadly. And here are calls to also celebrate awareness of these different groups in terms of HIV/AIDS as well. So in terms of key takeaways, first, I want to remind you that HIV remains a leading public health problem, and the lessons we've learned in HIV can provide important lessons as we look towards the COVID pandemic and the potential impact of COVID on brain behavior relationships. And what we've learned in HIV, I think, can significantly inform the research that is emerging in that area. Second, I want to remind you that brain behavior relationships are not one size fits all. We know that, I hope that the data I've showed you today will convince you that it's important to take really important, real care to look at groups individually to see what different types of sociocultural factors might be impacting their brain health and their neurocognitive test performance. And as we've talked about here, there are a number of sociocultural factors that do bear consideration, especially quality of education, quality of education, acculturation, socioeconomic status, and discrimination. And that it's critical for us to incorporate these factors into our research and our clinical work in order to improve our understanding of these relationships, to reduce the risk of misdiagnosis, and better inform care and diagnosis, care, and ultimately public health. And lastly, I urge us all to consider our intersectional identities in people living with HIV. So things like not just ethnocultural status, but also age and the aging demographic that we're working with now in HIV, LGBT status, and other factors that I believe can all come to bear as we think about brain health. And really what we're working towards is brain health equity. What I argue what we want to see is a fair distribution of brain health determinants, outcomes, and resources within and between these different segments of the population, regardless of social standing. But until we as researchers, until we start really integrating diverse groups into our work and sociocultural factors that can impact brain health and cognitive test performance, we're not going to get there. And this is really important for us to consider. And also, I would argue that we need to expand our framework when we think about brain behavior relationships. So this model is based on a paper that I published back in 2008, in which I called for us to explicitly incorporate social and cultural factors into our disease models as we think about all conditions that affect brain health, but certainly especially HIV. And lastly, I want to just highlight how important it is to think about health disparities if we're going to end the HIV, if and when we end the HIV epidemic. To do so, to end this epidemic, we need to address health disparities. So there was this really important report that just came out talking about this, and how this unequal, access and progress that we've seen in the United States, especially in the South and in minoritized communities all over the United States, is hindering our ability to end this epidemic, which we can and will do. But health disparities has to be a key component in doing that. And with that, I want to acknowledge my wonderful lab and collaborators at Mount Sinai, at Queens College, and my wonderful alumni as well, and our funders who've made this work possible. And with that, I'm going to say thank you. That's it. I'll turn it over.
Thank you, Monica, for this really valuable and timely presentation. So to everyone on the call, as I entered in the chat, feel free to unmute yourself and ask any question you may have, or you can enter your question into the chat directly to join the queue.
I have a question. Bob, you could go.
No, go ahead. You first, Ruben.
Great talk, Monica.
Thank you.
Really, I guess I have a big question I don't expect you to have an answer for, but when it comes to those sociocultural dimensions of neurocognitive testing, what do we do? There's a lot of problems there, I think, with some of the tests, even how they're administered, the stereotype threat thing. And there are a few people out there working on this, but there seems to be a very difficult thing to address, from norms to even, some of the, one of your students who also has been working with me, Meryl, just published a paper looking at these interviews of South Africans taking neuropsychological tests for the first time. And one of the things that really stuck out to me in regards to the race mismatch, not that that was a case there, but given the test, there's some tests are timed and you're told to stop. And one of the people said, oh, yeah, you told me to stop out of the blue. I felt like I was just getting it, really getting into it. And then you told me to stop. And I thought, oh, I'm doing something wrong. I'm not very smart. And I always think, how does that then affect how you do on the rest of the test? Because all of a sudden something's activated in you where you're questioning yourself and you're questioning the situation. So it's a big question, but I'm just curious to hear your thoughts on that.
So thank you, Dr. Robbins, for that excellent question. Actually, I'm going to go back to my slides for a moment. So it's a really hard problem. And Madal, my student who you're working with, who I'm so grateful for, has just published that wonderful paper with you, which I'm so proud about. We also published, to answer that question, this chapter, which is focused on culturally and linguistically diverse older adults. And we came away with, after doing a really deep dive of the literature, with some clinical pearls that I think this is more at the clinical level than I think what you're asking, but there are a couple of things that I think are come to bear here. So I think we have to acknowledge that we have significant issues with construct validity with these measures. Many of these measures have not been really tested in terms of their performance with these different groups. And we also know that norms are not a panacea, right? They're not going to fix all the problems. We can't have norms for all of the different populations, and they're not a panacea for all of these challenges as well. So in terms of how we move forward now, so I don't want anybody to lose hope. I think we need to do the work as best as we can. And I think the way we do that is by maintaining a sociocultural lens where we think about, sociocultural factors with every measure and every assessment that we do, that we use the best available tools and norms that we have. And I want to highlight the great work that you're doing, Dr. Robbins, with, these digital assessments that I think you're taking a very culturally tailored approach with. And I think that's really going to be our way forward, right? And so in terms of how we move forward is by having measures that are, validated, standardized, and tailored to these, or at least including these diverse populations, which many of the tests that we we have so far are not. So there's this issue of goodness of fit that we need to handle, because we can't give up and stop assessing people, right? We can't do that because, as investigators, as clinicians, we need to continue to work with these populations, but we need to do it in the best way possible, the most ethical way possible, which means that we have to increase the goodness of fit between our imperfect tools and norms and measures and the populations that we need to study and serve. And the way that we do that right now, until measures like that you're working on are available, more broadly, until that happens, I think that we need to be very mindful and really kick the tires for every single test that you're going to use, and really look at the validation samples and the norms that you're using. I've been in really big rooms with board certified neuropsychologists, and when I've asked them, how many of you know the reliability and validity of the measures that you're using with diverse populations? To their credit, many people will say that they don't know. And I think that's a problem. I think our field has, been doing a disservice in that way. So we need to really understand the tools that we're using and their limitations. And then when we analyze the data, to interpret it in the context of other really important sociocultural data that you've gathered, like, readily available measures of quality of education, of acculturation, of SES, so that we don't over-pathologize populations, and that we utilize these sociocultural measures to really understand what's going on. And then that, I think, can help us increase our diagnostic accuracy and then better inform treatment. How's that?
Great, thank you.
You're welcome.
If I can jump in. Yeah, I mean, my question was similar, and it's hard to, first of all, I mean, you presented so much wonderful data, and you highlighted the complexities, the interrelationships of, sociocultural, language, other socio-demographics, et cetera. So I was trying to compose a similar question to Ruben's, and he got nicely into even just the sort of cultural way of administering tests and how people experience them, and issues around, I think, authority and power and how the test is administered, right? And I was thinking about, similar things in terms of, look, I think this has plagued psychology and for centuries, and intelligence testing, et cetera. Yep. How biased is it by, the culture that develops the test, et cetera. So I'm just sort of inviting even more, but your answer to Ruben was great. So I'm not sure if I have a real specific question. So I was thinking, like, even where the tests are developed and how they're developed. So I'm trying to tease apart, like, what really is a brain change versus the way we're measuring it. Yep. And the performance on the test. And how much, I guess I'm not aware of this, how much of these kinds of testing are actually developed in different societies and cultures, and not just what's being tested, but how it's being tested. I mean, I feel like it's come from a Western world. And is there, I mean, like, going back to scratch, like, are there testings and approaches that are being developed from other cultures?
Right. So that's such that's like, it's a Gordian knot. It's a really deep issue that you're bringing up. And it's interesting. So I have a whole other lecture on this, on like the historical underpinnings and legacy of intelligence and cognitive testing. And I'm not going to bring up those slides because I just want to talk with you, but I could come back and talk about that at length, because I think that really gets us to where I hope we want to get to in terms of really taking an anti-racist, decolonized approach to neuropsychological research. And it's its own lecture. And I really wanted to focus on HIV and disparity. So I didn't bring all that in, but you are right. Going back to, to the beginning of our field in psychology and specifically neuroscience and neuropsychology, that is, we have a racist legacy that has served to promote a lot of these eugenic, conclusions that people have taken, and really I think eugenicist research that psychologists did in the early 20th century informed, provided data against, it's pseudoscience, pseudo data, but provided the data that jumped the Atlantic and informed Hitler. And he literally cited American scientists, psychologists in Mein Kampf talking, to provide a rationale, a very flawed rationale for the genocide that he and they perpetrated. And so I think that is very much part of our legacy in westernized neuropsychology that we need to own, that I didn't learn in my graduate classes, and I only myself started teaching, and learning about in the last 10 years. But there are really like two branches in neuropsychology. One is this, the westernized approach that I think we've all been, indoctrinated in and learned it. And there's a lot of value to this very quantitative approach. And I think it's really important and necessary. And listen, I came out of, Halstead Raytan, hardcore, education and training. My mentor was Bob Heaton, right? But there's this other neuropsychology, the Russians, so Vygotsky and Luria, that really took a very sociocultural lens to neuropsychology and much more of a process approach. And really a long time ago. So we're talking about cultural neuropsychology like it's a new field in the last 10 to 15 years. And I guess explicitly it is. But Luria and Vygotsky were talking about the impact of culture on brain behavior relationships a long time ago. And so so what I'm talking about, I talk about with a lot of humility, and I want to acknowledge that historical context. And so where does it leave us now? I think that it leaves us at a point where we're only getting part of the story with the type of neuropsychology that's and neuropsychological research that we've been doing for the past 25 50 years, and so since and if we take it into the context of HIV and health disparities, I think that it's only really in the last 10 15 years that we've really started looking more explicitly at these cultural factors. And I think, to your point, and just really sticking with these HIV disparities, you could say, well, are these disparities real, because there are flaws with our tools and there are flaws with our norms. So maybe it's just all noise is what we're seeing. But what I would argue to you in that other slide that I showed, the between group differences, we see within group differences in neurocognitive functioning. So that's a clue that there's something actually really happening. Also, we see that when we take out ethnicity and we look at other cultural factors, that is accounting for important variants that I think we need to be thinking about and concerned about. So do I think that the disparities are real? I do. And I think that I believe that because they're related to other comorbid conditions that I think increase the likelihood of brain health disparities. And I didn't even talk about it. We have some really interesting research on blood pressure that we'll be publishing hopefully soon. It's in manuscript central purgatory right now. But things around blood pressure and other indices of health that I think really help persuade me to think that this is real, and these other sociocultural risk factors persuade me that these health disparities are real. And we can, if we expand our armamentarium of tools to account for these different factors, these sociocultural factors, as important ways of understanding brain behavior relationships, I think we'll get more at the truth of these disparities. I don't know if that's helpful, but that's what I got.
Very helpful, very thoughtful. I mean, I'm impressed with your brain and how you put together all of the complexity and the historical and the legacies and everything else. So
thank you.
So thank you. And I hope we can think about another exchange or a seminar about other things that you have that you can share with us. Yeah.
Happy to come back always. Any other questions, comments, or criticisms? It's all welcome.
Feel free to unmute yourself if you have a question.
Yes, please.
I have another one, but I don't want to take. How do we translate all of this into? I was just thinking, there really is a need, in HIV to help providers out there figure out who's struggling with these cognitive problems. And you know, and that's at the like primary care level, because that's where people go to get their medications and they have contact and a relationship with their primary care provider. And everything you just talked about is so, you're an expert, you think about these things, you go to sleep and, you know, can't fall asleep at night because you're thinking about these things. Some of us here, you know, also struggle with these things in our work, but to get that down into a way to help people, one, there's just not even really clear policies on who should be screening and what kind of screening test should be used, but there's, on top of that, there's this whole cultural overlay. And how do we begin to bring that to providers who want that information to help their patients, and patients to help understand how they're to, you know, take care of themselves?
Yeah, I'm thinking about that a lot actually right now. I am losing sleep about it, especially, you know, since the pandemic has started and these issues just, you know, it's a lot, right? It's a lot. And so how do we make, you know, that actual change? And I think that we can't accept the status quo, I think. You know, business as usual is not helping the health of these vulnerable populations. That much is clear. So and you know, and I saw this amazing talk by and I'm going to be a little provocative right now, so everybody just bear with me. So that's my caveat emptor. I saw this amazing talk I guess a year and a half ago by Dr. Inouye, who is now a dean at Arizona State, and he does writing studies. But his talk, so I saw him at Fordham, and his talk just blew me away, because what he was talking about white supremacy and anti-racism, and this was 6 months, 9 months before George Floyd, before the pandemic, you know, before our world literally got, you know, changed upside down. And basically what he said was, and so this is him. He said, you know, if we keep doing things the way that we're doing them, like business as usual, everything at the default is basically engaging in a racist approach, you know, to the work, to healthcare, and that we have to actively be acting in an anti-racist way to mitigate the effects of you know, living in a racialized, you know, patriarchal, you know, transphobic, you know, heteronormative society, all of those things, and that we actually have to be actively doing that. And so how do you actively do that? Because I think that's kind of the underpinning of that question you're asking, Dr. Robbins. And what I would argue to you is that I think that we have to change the way that we're training people who we're training to do the work. We have to train the people who are in primary care and working with people, and we have to train the investigators, like all of them, all of them have to, I think, you know, come to grips with this. And this is something that I think we have to engage in co-learning together. There's no, you know, no magic, you know, button or antidote. But I think that if people learn about how to approach, if they learn about the literature and they learn, you know, about their own biases, you know, I guess now I'm really talking about cultural competence, but I think by actively, you know, it's a 3-step process. It's my 2010 paper, Call to Action to Increase Culturally Competent Services in Neuropsychology. And so people need to, you know, understand their implicit biases, attitudes, and issues, all of us, including myself, because this is not a me problem, a you problem, it's a we problem that you're talking about. All of us need to confront our internalized racism, sexism, transphobia, heteronormativity, like all of those things that hinder health and public health in, you know, here in the United States and globally. That's number one. Number two, I think we all need to get educated about what the science actually does have to say and offer, and not to be so overwhelmed by what we don't know, but what does the good science that we do have, how can it inform our care? Because we want to engage in evidence-based care. So how do we do that? What does the good literature say? And then the third part is then to engage in, you know, culturally responsive, culturally humble, anti-racist care and treatment and diagnosis and assessment, and to consult with experts when you don't know. And I think that there are lots of people trying to do good work. And I feel like a lot of us, I don't want people feeling bad. I want us to be solution focused and figuring out what we can do right together to improve public health, because we can do it. It's not an unsolvable problem. I think it just takes time and effort consciously. That's what I think. Is that helpful?
Oh, definitely. Yeah.
I think
Thank you.
so. I mean, I hope maybe there's someone else who wants to ask a question, particularly maybe one of our fellows, but I just want to add a nugget. I was thinking in response, I mean, your response was great, Dr. Mindt, and to Ruben, but, I did this is many years ago. I did during my internship, I did a neuropsych rotation at the Brooklyn VA. And one of the things that always stuck with me from my mentor there, who I can't recall his name, I was learning the Lurie and Nebraska battery and all the kinds of testing and doing all that testing. But I remember what stuck with me. He said that the most you can learn from doing a neuropsychological assessment is doing a good history. So in other words, I guess what I'm inserting in here is maybe more of what we need to pay attention to is the self-reporting of a person's experience of how they're functioning, what has changed, their ability to concentrate on, I mean, because everything we've said and you've said, but I think maybe we need to pay more attention to stories of our patients, our participants, to understand whether something is really going on there or not.
Yeah, well, I totally hear you. I think that's a really important part of this puzzle, right? Because when we think about, our life as scientists, no one piece of data is truth. As scientists, what do we love? We love converging data, right? Like we love the converging data because that's where we get an idea of what the truth of whatever the question is actually, what it actually means. And so I think that when we look at just neuropsychology scores in isolation, we're missing the boat. If we just look at, one score on, a sociocultural measure, we're missing the boat. I really resonate with what you're saying. Really, we have to be integrative about it in a systematic way where we take in that self-report, we take in those neuropsychological data, the biological data, the medical data, the sociocultural reports, we put it all together. And in that chapter that I shared earlier, I talk about how you do that data integration with just what you're talking about, how important that history it is in all of it. And sometimes, you might not be able to get at the truth of the matter at time one. You might need to bring somebody in and monitor them over time to really get an understanding of what's happening, right? If you don't have, good referential norms to help you. So I think it's all important.
Exactly.
Unfortunately, our time is coming to a close. This has been such a great discussion. Thank you again, Monica. Bob, if you have any closing remarks.
No, just another thank you, because it was really so comprehensive and so well articulated in thought. And I hope we can have more discussions and workshops and seminars with you on this.
Wonderful. I would love it, Dr. Remien. And thank you all so much for being here today. I really appreciate it. I know how busy everybody is and just, it's a tough time. So thank you so much. It's really been a pleasure and an honor to be here with you today. Thank you.
Yeah, everyone be well, and we look forward to seeing you on March 18th for our next HIV Center rounds.
Bye, everybody.
Thank you.
Ciao.
Bye. Thank you.